Okay, so today I'm going to be talking about lateral ankle sprains, more specifically using evidence-based research to talk about the risks, diagnosis, treatment, return to play, and prevention of lateral ankle sprains. So what is a lateral ankle sprain? A lateral ankle sprain is an acute traumatic injury to the lateral ligament complex of the ankle joint as a result of excessive inversion of the rear foot or combined plantar flexion and abduction of the foot. They are the most common musculoskeletal injury among athletes, and this is because of the anatomy of the ankle. So these pictures on the left are going to show you, the bottom one shows you the ligaments of the lateral ankle. So one is going to be the anterior talofibular ligament, two is going to be the calcaneofibular ligament, and three is going to be the posterior talofibular ligament. Those support the lateral aspect of the ankle, and then not pictured is the medial side of the ankle that is supported by the deltoid ligament. And then the top picture is demonstrating how the lateral malleolus at the bottom of the fibula sits more distal than the medial malleolus on the tibia, causing a bony blockage when somebody everts compared to when they invert, so it's easier to have that inversion mechanism. So then to just put some numbers in here to show you a perspective of how common this is among athletes. In the US, there's approximately 2 million acute ankle sprains that occur annually. Among college athletes, it was found that 15% of the injuries reported were ankle sprains. In high schools, that number was 15 to 17%, and then in elite professional athletes, that number was close to 20%. They're typically reported in sports characterized by running, jumping, and cutting, so things like basketball, football, volleyball, soccer. They believe that the high incidence rate could be due to the frequency of re-injury. So once you have a history of acute ankle sprains, it's a strong risk factor to continue to have ankle sprains. They say up to 3.5 times as likely, which leads to chronic ankle instability or laxity and mechanical instability of that ankle. Next, we will talk about some risk factors. So we have some intrinsic factors, extrinsic, and then the anatomy that we were talking about, and then the biomechanics. And then this chart on the side is showing from when a study of collegiate athletes and what they found in that study. So for age, the highest amount of ankle sprains is in females between 10 to 14 years of age, and for males, it's between the ages of 15 to 19. So if you think about it, these are the ages when females and males are going through puberty, so their bodies are changing and they haven't been able to figure out how to use them yet, so that makes sense. Then next they talk about sex, and actually for sex the study did not find a significant difference between males and females. They even compared comparable sports, so like baseball, softball, basketball, soccer, track, etc., and did not see a difference overall. Next, body composition. They found a higher rate of lateral ankle sprains in athletes with a higher BMI compared to those with a normal BMI. For health history, as we just talked about previously on the last slide, those who have a history of those lateral ankle sprains have a higher chance of re-injury. And then next is muscle strength and physical fitness. So inadequate strength of the ankle and hip joint muscles can heighten the risk of lateral ankle sprains. So think about the kinetic chain. So asymmetries in the dorsiflexors and plantar flexors were a risk factor for lateral ankle sprains, and then reduced hip extension strength was also found to be a risk factor in this study specifically. And then last one for intrinsic factors was postural balance. And they just found that impairments of posture and balance increase the risk of lateral ankle sprains. So you'll see later in this presentation that when they're doing rehab and stuff, they incorporate balance exercises. And then for the joint anatomy and psychological factors, we already discussed previously on the first slide that due to the ligaments and bony structure, it's more likely to have an inversion mechanism of injury and hurt the lateral side of your ankle compared to the medial side. And then psychologically, athletes with a past may be more timid, causing them to have wrong movements, or the opposite. Some athletes are too competitive, too aggressive, and could injure themselves in that way. And then also they added in about sports. So obviously those who are in sports that are like running, cutting, and jumping are more predisposed to the lateral ankle sprains. And then biomechanically, they typically occur in transition from non-weight bearing to weight bearing. Usually it's a rapid increase in inversion, internal rotation, and usually some plantar flexion. The inverted position of the ankle joint at the initial contact is particularly a vulnerable position and the most common mechanism of injury for the lateral ankle sprain. So that is pictured in this small picture you see right below biomechanics. You see a little bit of plantar flexion there and then that inversion twisting mechanism. Next, we have a differential diagnosis and special test. So you have to want to take a thorough history, careful inspection, and palpation should be performed then. You want to start your way at the knee, working down into the foot. So you want to palpate the calves, the higher ankle to rule out a syndesmotic ankle. You want to palpate all the ankle ligaments. So even if they are not having that pain on the medial aspect, you still want to palpate just to make sure, palpate the Achilles, palpate all the bony landmarks to make sure there's no fractures, look for swelling, discoloration, and then special tests that a study I found showed that would be the best performed along with range of motion and strength. They have the anterior drawer test, the posterior drawer test, and then the inversion stress test, which we typically refer to as the Taylor tilt test. So first, the anterior and posterior drawer test. The patient is going to be supine or seated. The knee is flexed to 90 degrees. Typically, you want the feet hanging off the edge of the table. The ankle is plantar flexed to 10 to 15 degrees. The clinician will stable the tibia and fibula with one hand while the other one grasps the calcaneus. You'll see this picture right over here. And then a low magnitude force is utilized to translate the subtalar joint anteriorly. That's the anterior drawer test. And then the posterior drawer test is the same thing. You are just pushing from the front on that talus, trying to have a posterior translation. So a positive finding is anterior translation of the talus and or pain over the ATF for the anterior drawer, and then for the posterior drawer, it is that posterior translation of the talus and pain over the PTF ligament. And then, so if you have a positive anterior drawer, it's an indication of a anterior talofibular ligament sprain, and for posterior, it's indicating a posterior talofibular ligament strain. The sensitivity for these tests are 74 to 83%, and the specificity is 38 to 40%. The next test is the inversion stress test, or Taylor tilt test, as we like to call it. The patient position, the patient's going to be seated with the knees at 90 degrees hanging off the table, the ankle is put into neutral. The clinician stabilizes the fibula and tibia again with one hand while the other one grasps the talus and the calcaneus. The clinician then provides an inversion and eversion force, rocking that talus back and forth basically is what they are trying to do. A positive finding is if the range of motion is greater than the opposite foot in the injured side, or there's pain with inversion, that indicates a calcaneofibular ligament strain. The sensitivity of this is 52% and the specificity is 88%. Next, we will move on to treatment and rehab. So an article from the Journal of Athletic Training found 4 factors that seem to be the most effective in enhancing patient function and reducing recurrent ankle sprains. So the use of NSAIDs, so non-steroidal anti-inflammatory drugs to reduce inflammation, along with ice compression and elevation, so that RICE policy or police if you are more up to date. Early return to motion instead of prolonged immobilization. So early on trying to work on that range of motion, ABC's forward ankle, that kind of stuff. You don't want to immobilize it for too long. The use of external ankle support or, functional ankle braces or tape for up to 1 year after injury to reduce the recurrence rate. And then finally, further rehab incorporating balance, exercise, and coordination training in the rehab plan as soon as weight bearing is tolerated. And then in this chart on the side, you will see they put these into the International Classification of Function, Disability, and Health, showing that you want to start nice and easy at a cellular level, using RICE, and moving into the tissues, continuing to use that RICE or police policy, and starting to try to get back some motion. So doing some 4-way ankles, some ABCs. And then next is the body, so coordination training, starting to do like balance and strengthening exercises. And then the last one, you want to, so between self and society, you want to start returning them to stuff that is sport specific, so then they can go back out and play in their sport. So along with treatment and rehab, I went on to the not a position statement of ankle sprains and treatment and prevention to find what they think is the best way to return a athlete to play after a lateral ankle sprain. And so there's 3 criteria. The first one being that the patient's perception of function using subjective questionnaires. So things such as the lower limb task questionnaire and the Cumberland ankle instability 2. So you can get, how the athlete is feeling about how their ankle is, what they feel like they can or can't do still concerning that ankle, or even just the lower limbs in general. And then the next criteria is functional performance testing. Things such as single leg hops for distance, the STAR excursion balance test. You want to make sure that these functional performance tests are sport-specific tasks, and performance on the injured limb should be at least 80% of what they can do on the uninjured limb. And then the third criteria is that they should be wearing functional ankle supports, either braces or taping, for all practices and games, so there's less likely to be a chance of re-injury. And then lastly, we go into prevention. So because one of the most prevalent risk factors is a previous history of ankle sprains, ankle bracing and taping can help prevent recurrent ankle sprains, give them mechanical support, neuromuscular effects, and physiological benefits. So while it is mechanically helping them, it also gives them kind of a peace of mind, that feeling of support. And then another way to prevent ankle sprains is if coaches and players implement exercises in daily practices to improve dynamic ankle stability to better withstand loads. So maybe in the warm-up adding stuff that includes bouncing, proprioceptive, and then in their strength training adding stuff, like working on the kinetic chain, not just focusing on one specific muscle, a couple specific muscles. And that is all.